What we're looking at here is a structured, evidence-based framework for handling high-risk emergency surgeries. The goal is to make sure our clinical decisions really line up with patient values, and we're going to do that by using validated, objective criteria to navigate these incredibly complex cases. This isn't just about the medicine. It's also about easing moral distress for clinicians, and of course, improving how we talk with patients and their families. So, we've broken this down into 6 core components. It's designed to be a logical path, taking us all the way from identifying the patient to making that final decision and getting it all documented. First up, let's talk about the mandatory activation triggers. These are the specific black and white criteria that say, okay, we have to start a formal multidisciplinary review. This really gets to the heart of the matter, doesn't it? When does a case cross that line and require this higher level of formal discussion? Well, the beauty of this framework is that it takes out the guesswork. It defines specific, non-discretionary criteria that automatically trigger the review process. And here's the key takeaway. If any single one of these 7 criteria is met, the protocol has to be activated. It's not a suggestion. These triggers, whether it's an ASA status of 5, a high SOFA score, or even a pre-existing DNR order, they're all based on validated models that flag profound physiological stress, and they tell us a formal conversation is absolutely necessary. Let's just zoom in on one of these for a second. The Sequential Organ Failure Assessment Score, or SOFA. A score of 12 or more is an automatic trigger. And this isn't some arbitrary number. It was chosen because it's directly associated with a mortality risk that exceeds 50%. All right, so that brings us to the scoring systems themselves. These are the quantitative tools that really form the evidence-based backbone for those activation triggers we just talked about. What the SOFA score does is give us a really detailed number-based look at organ dysfunction. It assigns points across 6 key systems based on very precise clinical thresholds, things like vasopressor requirements, specific lab values, and the Glasgow Coma Scale. And as you can see here, there's a really clear, direct link between the SOFA score and mortality risk. That total score gives us a powerful prognostic prediction. It scales all the way from less than 10% mortality up to around 90% for scores of 15 or higher. It's a seriously powerful tool. Now, SOFA isn't the only tool in the toolbox. We also use others, like the NELA calculator, which is incredibly specific and accurate for emergency laparotomies. Then you have PPOSSUM. It's validated for general emergency surgery, but, and this is an important nuance to keep in mind, it does have a known tendency to overpredict mortality in modern practice. Okay, so what happens when things start to look really grim? That's where we get into the criteria for decompensated organ damage. This part of the framework spells out the objective thresholds that help us identify when a patient might be in a state of irreversible physiological decline. So let's look at the cardiovascular system. We have specific vasopressor requirements that define refractory shock. And what's really interesting here is just how dose-dependent the prognosis is. A norepinephrine equivalent dose hitting 1 microgram per kilogram per minute, that's associated with only a 17% survival rate at 90 days. It's a sobering number. So how do we know if we've crossed a point of no return? Well, there are a few really powerful markers. For instance, the failure of 4 or more organ systems at once carries an 83% mortality rate in the ICU. Another huge red flag is a persistently high SOFA score that just doesn't trend down over 5 days. It suggests that our therapies just aren't working. So once a review is triggered, what happens next? This 4th section lays out the whole procedural timeline and the essential communication elements that have to be part of the multidisciplinary discussion. The whole process is tiered based on how urgent the situation is. If you've got a life-threatening condition that can't wait, it's an immediate review, and a decision gets made in under an hour. For cases that are less time-sensitive, an expedited review gives everyone up to 12 hours for a more thorough deliberation and to get the family more involved. And here's something that's a non-negotiable part of this discussion, using the best case/worst case communication tool. This is a validated framework that forces a structured conversation, making sure we clearly lay out the entire spectrum of potential outcomes, from the best possible result all the way to what happens if we do nothing, so the patient or their family can make a truly informed decision. Okay, so after all of that discussion, the review leads to one of 5 explicit, documented clinical pathways. Think of these 5 pathways as the standard playbook. They give the entire clinical team a really clear framework for documentation and, more importantly, for action. And the great thing is, these pathways are incredibly clear and they're all about action. They run the gamut from pathway A, which is just proceeding with the original surgical plan, all the way to pathway D, which is transitioning to comfort-focused care. And then you've got pathway E, which is reserved for those tough situations where we can't agree, and we need to kick off a formal conflict resolution process. All right, last but certainly not least, let's talk about the paperwork and what happens when people don't see eye to eye. This last part covers the critical requirements for documentation and the protocol for managing conflict. And the documentation here has to be thorough. We're not just talking about a quick note. It's a detailed record that has to include the specific triggers that started the review, all the scoring calculations, who was there, what was discussed, and of course, which final pathway was chosen. So what happens if you get to a point where there's a real disagreement? Maybe a family is requesting a surgery that the team feels is inappropriate. Well, the policy defers to this multi-society framework. And the goal here isn't about winning an argument. It's about making sure there's a fair, transparent, and professional process for working through these disagreements. And really, all of this brings us to one final and I think crucial question for all of us. This framework provides a robust, evidence-based model, so it's an opportunity for every single institution to take a hard look in the mirror